Hello, welcome to Trauma Series 10. Today, our topic of discussion is pediatric trauma. So, first of all, we think of why we need to study about pediatric trauma. There are some unique characteristics for pediatric age group. In case of anatomy, in case of physiological status, everything, the pediatric age group is different from the adult. So, we have to learn it separately so that we will understand the concepts. Let's look at the common mechanisms of injury in pediatric age group. First is pedestrian struck by a motor vehicle. So it can be a low speed injury or a high speed injury. If it is a low speed injury, we will have a lower extremity fractures. If it is a high speed injury, we have multiple trauma, including head and neck trauma and extremity traumas. Occupant in a motor vehicle collision, it can be unrestrained or restrained. In case of unrestrained, there can be multiple trauma. In case of restrained, it can be chest and abdominal injuries, lower spinal fractures also. Fall from a height. If the kid is falling from a very low height, there can be upper extremity fracture. If it is very high, it can cause multiple trauma. And fall from a bicycle without the helmet and with the helmet. If without the helmet, then head and neck lacerations can happen. With the helmet, then upper extremity fractures are more common. And striking the handlebar, internal abdominal injuries can happen that we will discuss in abdominal injury part. There are some unique characteristics for pediatric patients. One is apnea, hyperventilation, and hypoxia is 5 times more common than adult in pediatric age group. So respiratory arrest is more frequently happens, and less fat and less connective tissue makes the internal organs more close to the skin and more chance of injury. And child head is proportionately larger, so causing more head trauma possible. And ratio of the child's body surface area to the body mass is highest. So it can dissipate more heat outside and cause hypothermia, more common than adults. Another factor which we have to consider is the psychological changes. When the kid is going through a trauma in a childhood, it can cause serious psychological problems in later on. And long-term effects of injury can be more in case of children. If the physis plates are involved in the bone trauma, then it can cause the growth abnormalities. And if there is any significant abdominal trauma and causing the spleen to get disrupted and splenectomy has been done, then there is lifelong infection risk is there. And if ionizing radiation we are using for multiple modalities of investigation, then it can lead to a tumor and induced cancers later on. And the equipments used also in pediatrics, we need to use all weight based doses of drugs and fluids. Let's look at some unique characteristics of the pediatric airway. These are the basic differences between the adult airway as well as pediatric airway. And in case of pediatric airway, we know that there is a large head and occiput is there. It may push the head forward and occluding the airway. And there can be a large tongue which may occlude the upper airway in sedated, obtunded, and paralyzed patient. And large adenoids and tonsils also may cause the upper airway obstruction. There can be a small cricoid cartilage which makes open thyroidotomy a difficult procedure, as there is a floppy epiglottis which may obscure the laryngeal view. We have to lift the epiglottis directly with the straight blade. And there can be cricoid narrowing, and the subglottic space will be the narrowest portion in the pediatric airway. And lower gastroesophageal sphincter tone will be low, and relatively small lungs make the insufflation of the stomach with bag and mask ventilation, and swallowed air can compromise the respiratory status, causing the kid more prone for aspiration and apnea during intubation. This is the proper positioning of an infant for intubation. Elevation of the shoulders is often needed to accommodate for the prominent occiput and prevent flexion of the neck. 2 centimeter thick elevation should be given to the shoulders. In an older child, the elevation of the head with the neck extension often results in the best alignment for intubation. Let's say regarding airway management. Intubation is often required when kid goes into respiratory failure or severe brain injury causing the tongue to fall back and obstruct the airway. Pre-oxygenation is very important aspect when child or infant is concerned. As the lung is having a small size and the vital capacity is smaller, child can go in for apnea or hypoxia very fast. In order to prevent the same, airway opening maneuvers and airway adjuncts can be used along with pre-oxygenation.
Airway opening maneuvers. As we know, the jaw thrust maneuver is the only modality of airway opening maneuver we can use while doing intubation in trauma patient. Avoid head tilting and chin lift maneuver in trauma. Make sure that the cervical spine is immobilized by the assistant during the intubation. Regarding airway adjuncts, in the absence of gag reflex, we can use the airway adjunct. Select the appropriate size of the oropharyngeal airway by measuring between the angle of the mouth to the angle of the mandible. 180-degree rotation method of insertion should not be used in children as a soft palate is highly friable and can bleed profusely if you do so. Regarding endotracheal intubation, cupped endotracheal tubes are preferred nowadays, but we have to be very careful about the cuff pressure. Keep the cuff pressure less than 30 millimeters of mercury, as the cricoid is narrowest part of the airway in kids and it can cause stenosis and it will cause very severe morbidity. Infants has more pronounced vagal response while compared to the adult. It is advisable to give atropine about zero point 0.1 to 0.5 milligram to dry up the secretion and prevent bradycardia during intubation. Size of the endotracheal tube can be selected by the diameter of the little finger of the child, roughly, or we can use the formula. And confirm the position of the tube by 5-point auscultation method. Do not do nasotracheal intubation because there is a risk of passing the tube to the cranial vault in case of any base of skull fracture. Stillet can be used to facilitate the intubation, but make sure that the tip of the stillet is not going beyond the tip of the tube when you use a stillet. When all the other modalities of achieving a definitive airway fails, we can go in for front of neck access or otherwise called as cricothyroidotomy. There are two types of cricothyroidotomy, needle cricothyroidotomy and surgical cricothyroidotomy. Surgical cricothyroidotomy can be performed in children more than 12-year-old, and if the child is less than 12-year-old, only needle cricothyroidotomy should be tried. The 3-2-1 rule of pediatric sedation drug dosages says that we can give 3 microgram per kg of fentanyl followed by the ketamine 2 milligram per kg and rocuronium 1 milligram per kg almost together to achieve the sedation and paralysis to do the rapid sequence intubation. Regarding selection of pediatric tube sizes, ET tube, uncuffed ET tube can be selected by the formula of age by 4 plus 4. If it is a cuffed tube, then use the formula age by 4 plus 3.5. ET size into 2 is the size of Foley's catheter or nasogastric tube. ET size into 3 gives us the depth of insertion of ET tube, and 4 times the size of ET tube will provide the size of chest tube to be used in trauma. Regarding special considerations of breathing, hypoxemia in children can be manifested as any degree of agitation, altered mental status, cyanosis, poor capillary filling time, and desaturation. In children, normal tidal volumes per kilogram of body weight are 6 to 8 ml per kg, which is usually more than that of adult and infants. Pediatric bag and mask should be used below 30 kilogram weight to prevent barotrauma and pneumothorax. Extreme bag and mask ventilation or excessive bag and mask ventilation will result in gastric insufflation. So, limit the squeezing of the bag just enough to get the chest rise in infant or child to prevent aspiration and vomiting. Hypoxia is the most common cause of cardiac arrest in children. So, before cardiac arrest, the child will develop hypoventilation. That means inadequate breathing. This breathing efforts will become inadequate and will develop respiratory acidosis along with. Remember, any attempt in giving bicarbonate in such respiratory acidosis will result in worsening of acidosis and faster cardiac arrest. So, focus on maintaining the ventilation and perfusion rather than correcting the acidosis. Regarding circulation and shock, in children and infants, the concept of shock is entirely different from that of adults. There are two types of shock in children. One is compensated shock, the other one is hypotensive shock. A child will present to us mostly with the compensated shock. Remember, once hypotension develops in children, it is just a matter of minutes. The child will crash and go to cardiac arrest. Regarding special considerations of compensated shock, classical feature is not having hypotension. Signs of poor perfusion, such as tachycardia, cold, pale diaphoretic skin, delayed capillary refill time, weak peripheral pulsations, raised diastolic BP, narrow pulse pressure, oliguria, vomiting, altered mental status will be there in compensated shock. In case of children, if BP is less than 70 plus 2x, then it is called as hypotension. If more than 10-year-old kid we have, then we take it as less than 90 millimeters of mercury as shock. The blood volume of an infant is 80 ml per kg. In child of less than 3-year-old, it is 75 ml per kg. And if more than 3-year-old, it is 70 ml per kg. Almost 30% decrease in the circulation volume will cause hypotension in kids. In decompensated shock, almost 45% of the blood loss would have happened. If we don't know the weight of the kid, we can estimate it by using the formula 2x plus 10, where x being the age in years. Management of hemorrhagic shock. If IV access is not able to access in 2 attempts, then we have to try an IO access. The preferred site for IO access is upper tibia and lower femur. IO access can cause osteomyelitis, cellulitis, etc. complications. And it should not be tried when we suspect a fracture in the bone. The initial fluid to be given to a kid is 20 ml per kg and reduce it to 10 ml per kg in neonates and the kids with cardiac abnormalities. Look for rales, respiratory distress, hepatomegaly before repeating another bolus. The maximum number of boluses we can give is 2 to 3 bolus. That means maximum of 60 ml per kg fluid can be given. Then start transfusing blood. 10 ml per kg of PRBC plus 10 to 20 ml per kg of fresh frozen plasma and 10 to 20 ml per kg of platelet as well. And note that you have to prevent the hypothermia, myocardial dysfunction, hypocalcemia during massive blood transfusions. Calcium administration can be considered during acute massive blood transfusions. Urine output target is 1 to 2 ml per kg per hour while we are transfusing the blood. So while we are assessing the response towards the fluid resuscitation, there can be responders, there can be non-responders. Responders means once you give the fluids and initial resuscitation with the blood, they will improve the signs of perfusion. In non-responders, even if you give the blood, they won't respond to your treatment. The transient responder is the one who shows initial response and deteriorate later on. So these are the group of kids we should be very careful while resuscitating. If if it is found that the kid is a transient responder or a non-responder, blood transfusion should be started immediately and early surgical consultation should be initiated. And children in cardiac arrest is another common presentation to the ED after trauma. When cardiac arrest occurred more than 15 minutes. Next, about disability. Disability assessment includes assessment of sensorium by GCS score or AVPU scale. Children are more prone for hypoglycemia, so frequently we have to monitor the RBS to prevent the hypoglycemia. GCS score of pediatric age group varies from adult in terms of verbal response. In case of kids who are not started talking, we can say that the coos and babbles of the kid can be considered as 5 score. An irritable cry can be considered as 4, and cries to pain is considered as 3, and mourning to the pain is 2, and if there is no response, then it is considered as 1. There is another score called as AVPU score, is more easier and can be applied quickly. A is for awake, V for response to verbal stimuli, P for response to pain, and U for unresponsive kid. So examination of the pupils for anisocoria will give an idea about intracranial hemorrhages following trauma. Regarding head injury, the child brain size doubles every 6 months and 80% of the adult size acquired by the 2 years of age. Regarding general principles of management, we have to give adequate analgesia, treat the raised intracranial pressure, and identify when to take a CT brain and when to refer to the neurosurgeon, and prevent secondary brain injury. So, hypovolemia and hypoxia will worsen the outcome of head injury. So, prevent hypoxia and maintain adequate blood volume in pediatric trauma.
Remember, intraventricular hemorrhage in pediatric age group will cause hypotension unlike adults. Open fontanelle in kids will accommodate more volume and less herniation chance will occur. And 3% saline and mannitol will help in reducing the intracranial pressure. We can take the decision of whether to do or not a CT in pediatric trauma by a rule called as pecarn rule. The pecarn rule is different for younger than 2 years and 2 years or older. In both the groups, altered mental status, GCS less than 15, or any palpable skull fractures in case of less than 2 years, and if any altered mental status, GCS of less than 15, or signs of basilar skull fracture in more than 2 years, we have to definitely consider taking a CT. Otherwise, we have to go for the next step. Next step, in less than 2 years, LOC more than 5 seconds, non-frontal hematoma, not acting normally according to mother, and severe mechanism of injury is there, then we have to consider taking a CT. Or we can observe for 6 hours according to the clinician's decision. If nothing is there, then no CT is required. In more than 2 years, if initial 3 signs are not there, then history of LOC, history of vomiting, severe headache, severe mechanism of injury we can see. If none of this is there, then no CT is required. If any of this is there, then we can observe or we can go for CT according to the clinician's decision. Regarding treatment of traumatic brain injury, so cervical spine motion has to be restricted and maintain the airway and intubate if a GCS of less than 8. Oxygen saturation more than 90%, PCO2 keep between 35 and 45, systolic blood pressure we have to keep more than 70 plus 2x of age, and GCS before paralytics we have to analyze if possible, and neuroimaging as decided by the pecan rule. Treat hypoglycemia if identified and avoid hypoglycemia. Treat raised ICP, maintain temperature between 36 and 38 degrees Celsius. Seizure prophylaxis we can provide as phenytoin 20 mg per kilogram or levetiracetam 20 mg per kg, maximum 500 mg per day for 1 week. And transfuse blood if hemoglobin is less than 7 gram per deciliter. Now, how to treat the raised ICP in pediatrics? Elevate the head end for 30 degrees Celsius, 30 degrees, and 3% saline 5 ml per kg bolus over 10 minutes, followed by the infusion of 0.1 mg per kg per hour to maintain the sodium level of 155 to 165. Mannitol 0.5 to 1 gram per kg initial bolus, followed by 0.3 gram per kg TDS. There is no role of any corticosteroids. Regarding thoracic trauma, remember that in pediatrics, the chest injury serves as a marker of other organ injuries. Mediastinal structures are mobile in case of children, so more pneumothorax can occur. Pneumomediastinum per se is rare. Regarding pulmonary contusion, most common injury during blunt trauma chest is pulmonary contusion. Interstitial edema or alveolar hemorrhage is a mechanism of injury, and pulmonary contusions evolve over a period of 4 to 6 hours. So, initially in the X ray, we may not be able to find the typical findings. And careful fluid management, fluid restriction should be done, and lung injury preventive ventilatory strategies as well as prophylactic antibiotics will help in the treatment of pulmonary contusion. In children more than 10 years old, more chance of penetrating trauma of the chest is possible, which causes pulmonary laceration. So, ongoing bleeding or air leakage from pulmonary laceration will warrant a surgical intervention in such cases. And about a pulmonary contusion, areas of contusion is more than 30% might require mechanical ventilation. Fluid restriction, early mobilization, analgesia will help to avoid the worsening of atelectasis due to pulmonary contusion. Pneumothorax. Pneumothorax present in almost one third of the pediatric trauma victims. Treatment of pneumothorax is needle thoracostomy followed by a tube thoracostomy. Diagnosis is done by ultrasonography. It shows a barcode sign with a lung point. Small isolated pneumothorax, we can observe the patient for 6 hours. If there is no increase in pneumothorax, we can repeat the X-ray at 6 hours and repeat the next X-ray in 24 hours. Clinical diagnosis is difficult
because of the false transmission of the breath sounds. In such cases, we have to empirically start treatment. About hemothorax, hemothorax is relatively less common, and each hemithorax can contain 40% of the blood volume in case of pediatrics. Surgical thoracotomy indications are chest tube output of more than 20 ml per kg on insertion, drainage exceeding 3 to 4 ml per kg per hour for 2 to 4 hours, and need of ongoing blood transfusion. Chest X-ray will show hemothorax when there is a minimum of 10 ml per kg of blood in the hemithorax. O negative blood or auto transfusion may be considered in case of hemothorax. Dealing with the tracheal and bronchial injury may cause death in the first hour of the trauma in case of pediatrics. Require CT chest for the diagnosis. In case of tracheal injuries, we have to avoid the blind airway procedures. If it is a distal and smaller injuries, a chest tube and continuous observation may suffice. Fiber optic intubation may be preferred in case of tracheal and bronchial injuries. Regarding tube thoracostomy and needle thoracostomy has to be done in the second intercostal space in the midclavicular line in case of pediatrics. And there is a tunneling method we have to follow while doing a tube thoracostomy. Putting the incision above the rib and tunneling through the subcutaneous tissue and entering the chest cavity through the upper border of the lower rib is preferred. Let's say regarding abdominal trauma. Pediatric abdominal trauma, as we know that abdomen is a Pandora's box. Now we will look at some specific mechanisms of injury which is causing abdominal injury in children. One is the Waddell's triad, where it's a basic mechanism of pedestrian hit by a motor vehicle. The first impact is towards the mid shaft of the femur, causing a mid shaft of femur fracture, and second impact is towards the abdomen, causing an abdominal injury, and the child is thrown to the ground, hitting the head, causing a head injury. The second complex of injury is called as lap belt complex, where the child is restrained as an occupant in a motor vehicle collision. The blowout diaphragm fracture can happen, and duodenal injury can happen, and solid organ injury with the chance fracture of the lumbar spine because of the result of as a result of hyperflexion injury. The third mechanism of injury is fall from height. Fall from height can potentially land on the head, uh, causing a head injury, causing multiple long bone fractures, and chest wall injury as well. What are the indications for a CT abdomen in a pediatric victim of trauma? Polytrauma victims with a history suggestive of severe intra-abdominal injury, concerning physical examination findings such as abdominal tenderness, peritonitis, or a seatbelt sign or other bruising, aspartate aminotransferase of more than 200 international unit per liter or alanine aminotransferase of more than 125 international unit per liter, and decreasing hemoglobin or hematocrit in case of gross hematuria also. And general principles of management includes a primary survey of ABCDE assessment, insert an nasogastric or oropharyngeal orogastric tube, cannot urinate, then catheterize the patient and send the urine analysis samples per rectal examination, including the bleeding PR, prostate position, and rectal tone. Keep the kid under NPO and any fast if positive, if possible, and blood investigations including cross match, electrolytes, CBC, and serum amylase and transaminases. Regarding specific injuries, regarding the splenic injury, that is the most common intra-abdominal organ injury, the vaccination against capsulated organisms becomes an important aspect after splenic injury, and antibiotic prophylaxis and pseudo aneurysm formation is possible complication after the splenic injury in pediatrics. Regarding the renal injury, injury to the kidney is associated with rapid deceleration mechanisms such as motor vehicle and pedestrian collisions, fall from height, etc. And clinical findings include localized flank tenderness, ecchymosis, palpable flank mass, penetrating wounds, proximity to the kidney. Microscopic hematuria is common after blunt trauma abdomen, does not require further investigation. If hematuria is having more than 50 red blood cells per high power field, we should suspect not just a renal injury, sometimes splenic injury can also cause the same finding. Let's look at the bowel injuries. One of the mechanism of bowel injury is the handlebar injuries, which you can see in the figure that there is a mark of handlebar in the right upper quadrant of the abdomen. Concerning hollow viscous injury, the visceral and mesenteric tears are the most common injuries, and visceral injuries may include the bowel perforation, bowel wall hematoma, and mesenteric tears as well. Handlebar injury, as I told, which will cause a duodenal injury most commonly, and the seatbelt injury complex will also cause mesenteric as well as bowel injuries. With small bowel injury, the chance fracture of lumbar spine is more common, present in more than 15% of the children with a blunt torso trauma secondary to motor vehicle collisions. And traumatic diaphragmatic hernia can be associated with hollow viscous injury also. So basically, there are two kinds of abdominal trauma. One is penetrating abdominal trauma, and the other one is blunt abdominal trauma. In children, the abdominal viscera begins at the nipple level. So potentially any injury between the nipple to the groin will involve peritoneal cavity. So essential treatment of peritoneal wounds are surgical evaluation, wound debridement, if needed, possible exploration, and broad spectrum antibiotics. So, gunshot wound in the abdomen needs immediate surgical exploration. One third of the stab wounds only reach the peritoneal cavity. So, most of the time, in peritoneal cavity, exploration might not be required. If no signs of shock, no signs of peritonitis, no blood in the stomach, rectum, or no blood in urine, no evidence of any free abdominal or retroperitoneal air in X-ray, no history or evidence of bowel injuries, omental evisceration. Of all these signs are not present, then we can safely observe without a surgical intervention. The blunt abdominal trauma, even minor mechanism like a fall from small height, will cause abdominal injury. So, X-ray clues of abdominal trauma can be there, including the air in the diaphragm. And we follow always ALARA principle, the as low as reasonably acceptable principle for abdominal trauma. Because whenever it is absolutely required, we'll go for a CT. Do a score called as BATIC score to know whether the abdominal CT will reveal a positive finding or not. If a BATIC score is less than 7 and normal Doppler abdominal ultrasound in a hemodynamically stable patient indicated very low likelihood of significant intra-abdominal injury. So components of a BATIC score are abdominal abnormal Doppler ultrasound, abdominal pain, signs of peritoneal irritation, hemodynamic instability, aspartate aminotransferase more than 60, ALT more than 25, WBC more than 9500, then lactate dehydrogenase more than 330, lipase more than 30, and creatine more than 50 microgram per liter. It was a long video. Thank you for listening.